Thank you, Mr. Chairman. To start, I would like to thank the organizing committee, Dr. Wiam, for giving me this chance to speak about one of the topics which are influencing our practice, our outcome in helping people conceiving and having children. I have noticed during my work in these years that thyroid is one of the most important gland in the assisted reproduction. And when patients come to us, we always check on the TSH and prolactin before we start any treatment. If these two are within normal, then we ask them to proceed and we accept them to have their trials. These are very important, and even if they stop treatment and come back after 3-4 months, we ask them again to check on their thyroid by doing the TSH and also the prolactin level, so that if they have any abnormality, we start treatment before we start their IVF treatment. IVF is a hyperphysiological status where we can reach with the estrogen to thousands of picomoles. Some of those patients who are having polycystic ovary syndrome, for example, their estradiol level can reach up to 5, 6, 7. I have seen some patients reaching 13,000. And especially the polycystic ovaries who are having huge ovaries and responding to even minimal stimulation with the gonadotrophins. So I will talk about the hypothyroidism epidemiology, how can thyroid affect the fertility, TSH, thyroid hormone and female reproduction, hypothyroidism, and the ovarian stimulation. And to my surprise, I have found one study coming from China about the paternal clinical hypothyroidism, and that its effect on the IVF outcome. Of course, thyroid dysfunction can cause different effects on the female physiology. It can cause short luteal phase, the second phase of the menstrual cycle, failure to sustain fertilization of the egg, and loss of early pregnancy. 50% of the hypothyroid patients will have menstrual irregularities in different forms, like the amenorrhea, hypomenorrhea, all these. And the TSH, prolactin, and growth hormone act synergistically on the follicle, and that will affect, of course, the FSH and LH and the growth of those follicles. Almost half of the infertile patients with hypothyroidism exhibit as well hyperprolactinemia. That's why we check on their prolactin at the same time. And of course, the hyperprolactinemia will also impair the gonadotrophin-releasing hormone pulsatile secretion, and this will cause ovulatory dysfunction at the same time. What's the impact on the male? On the male, the thyrotoxicosis is having an effect on the motility, while the hypothyroid is having the effect on the morphology of the sperm. And both motility and morphology are very important. And these are each one is important in the assisted reproduction, especially the infertility treatment with the ICSI procedure. The prevalence of hypothyroidism, as my colleagues have stated before, ranges between 2 to 4%. The females are 8 times more affected, and the hypothyroidism in the male is very rare to occur. The prevalence of abnormal TSH in the infertility population, those patients who are having anovulatory infertility, like the polycystic ovary, are having 6.3%. In the unexplained infertility, 4.8%. Tubal factor infertility is less, of course, 2.6%. And in the male infertility, it is even less, 1.5%. In one study, 23% of women with hypothyroidism had irregular menstruation and anovulation. This study was done to show how much is the percentage of those subgroups, the primary hypothyroidism, primary hyperthyroidism, and subclinical hypothyroidism. And I think reviewing the cases we are treating in our center, it's almost the same. We have between 10 to 15% of our patients having primary hypothyroidism, and they are on treatment. That's why I'm saying almost the same. But 3/4 of the patients who are having infertility and coming for treatment are euthyroid. Of course, in the fertile age, hypothyroidism, as we said, affect the menstrual pattern, but high frequency of infertility and hypothyroidism may be due to altered estrogen metabolism. That's why when we do hyperphysiological stimulation to the ovaries, we see high ratio of estradiol, also hyperprolactinemia, and a disturbance in gonadotrophin releasing hormone secretions. This is definitely affecting the infertility treatment. And also, T3 and T4 are necessary for the proper functioning of the reproductive system of the female, which includes, of course, the ovaries, the uterus, and the placenta. And we see that with the folliculogenesis, with the production of the oocytes, of the eggs. When the thyroid hormones are altered, we get bad quality oocytes. Bad quality oocyte meaning we are going to have a failed IVF trial, because only good quality embryos will progress and develop until they are becoming a real baby. Of course, the thyroid hormones affect also ovulation, and after ovulation, the corpus luteum is also affected, and the granulosa cell surrounding the eggs is also affected by the normal T3 and T4. A woman who is having hypothyroidism, the ovaries will produce few mature follicles. Follicles are the cysts that contain the eggs. If we have few eggs, then we have less chance of having embryos to be transferred. That's why it's very important to have a normal level of thyroid hormones. Also, prompt ovulation happen less often with the patients who are treated, for example, not with assisted reproduction, but with medications when we give stimulation to the ovaries. Also, the maturation of the corpus luteum will be delayed. All these will affect the pregnancy outcome later on. So what happens when we do ovarian stimulation? When we do ovarian stimulation, the free T4 will be decreased, and there will be increase in the estradiol level because of the physiological, hyperphysiological status. The TSH will be increased, and thyroxine binding globulins will increase as well. Total T3 will increase, and as well total T4. And this is, of course, in the overt hypothyroidism, it is associated with increase in spontaneous abortions, premature delivery of the babies and low birth weight, fetal distress in labor, and gestational induced hypertension and placental abruption as well. All these are linked with the subclinical hypothyroidism. Thyroid function and IVF outcome when we have subclinical hypothyroidism and TSH exceeds 4 or 4.5 before we start IVF treatment, we look at the replacement of the thyroxine with levothyroxine so that the patients are prepared. And of course, our target is to have a TSH on the range of 2.5. Of course, hypothyroid patients who conceive after gonadotrophin stimulation or with oral medications like clomiphene citrate for ovulation induction do not need additional thyroid supplementation compared with those who conceive spontaneously. TSH level, of course, our target always is to make the level of TSH around 2.5. But Stuckey has reported 2 cases where they converted from subclinical to overt hypothyroid cases during IVF treatment. Thyroid hormones appear necessary to achieve maximum fertilization rate and have also a special role in the oocyte physiology. That's why we should have a proper level of TSH so that we can have the best outcome of our IVF. And TSH level is a significant predictor of the fertilization failure for those women who are undergoing IVF treatment. The preconception TSH level of 2.5 again is associated with lower gestational age at time of delivery and lower birth weight in women undergoing IVF. Who are more than 2.5 the level of the TSH. Indeed, we need to maximize this by having a TSH level around 2.5 before pregnancy in those patients who are treated for hypothyroid status. This study comes from Iran. There are no unanimous agreement on the treatment with levothyroxine in cases of hypothyroidism. In this study, where they compared the TSH, which is less than 2.5, and TSH more than 2.5, and found no difference. No difference regarding the number of eggs which are good for fertilization, which is the metaphase 2 oocytes, and the number of embryos transferred, the type of transfer, whether it is fresh or frozen, the protocol which is used. Of course, we have different protocols for different cases. The use of long protocol in stimulation is the standard one, and there was no difference in the protocol itself. And again, the outcome, which is the clinical pregnancy, the end point, there was no significant difference between the two groups. Also, this study from the Andre group, they have found that the clinical pregnancy, again, no difference in the clinical outcome between the two groups who are having less than 2.5 TSH and those who are having 2.5 and more. The clinical pregnancy is almost the same, no significant difference. The delivery of the cases is the same, and the miscarriage is almost the same. So these two studies were showing us that there is no difference whether we used treatment or not. This study comes from China, and in this study, of course, they advise to have levothyroxine treatment because it improves the embryo quality and pregnancy outcome. And there was no difference in patient characteristics between the groups who are having levothyroxine treatment and the control group. And the total dose of medication used, the FSH, was similar. But the number of grade 1 and grade 2 embryos, which are the best embryos to be transferred, was significantly higher with those patients who had levothyroxine treatment. And there was no significant difference in the clinical pregnancy rate per cycle between the two groups. The miscarriage rate was significantly lower with the levothyroxine treated group, and the embryo implantation rate and live birth rate were significantly higher in levothyroxine treatment group. Of course, all these gives us a support when we are using the levothyroxine in our treatment. This is another study, which was a retrospective study talking about the relationship and the outcome of the treatment and no treatment. Going to the paternal subclinical hypothyroidism, does it affect the outcome of the in vitro fertilization, especially when we are using intracytoplasmic sperm injection? There was no significant, this study comes from China as well. There was no significant difference in the semen volume, sperm concentration, progressive sperm motility, morphology, and the DNA fragmentation between the two paternal groups in the subclinical hypothyroid. The study was about the female patients whom their husbands are having subclinical hypothyroidism. And the adjusted fertilization rate, good quality embryo, and the blastocyst formation. The blastocysts are the day 5 embryos, which are the best to be transferred and having the higher pregnancy rate, were all similar between the paternal subclinical hypothyroid group and the euthyroid. And the adjusted clinical pregnancy rate and implantation rate were significantly lower in the paternal group than the euthyroid, but there was no significant difference in early miscarriage rate between the two groups. You can see the good quality embryo, which I'm talking about, on the left side. This is grade 1 embryo that will lead to the best outcome of our pregnancy and the higher success rate. And the next is the poor quality embryo. You can see that these embryos are not symmetrical in their cells and having fragmentation. Next is what we call blastocyst grade AA, which is the highest and best quality, and that's our aim in the treatment of IVF. And of course, the spermatic morphology is very important, and we use magnification which can reach up to 600 times to make sure that the morphology is strictly correct, and we use something called Kruger's criteria to classify the sperm morphology. And the next slide, what's called the sperm DNA fragmentation index. And this is used to know how much of those sperms are good to fertilize the eggs, and those who are having a shiny color are the good type of sperms, and the DNA fragmentation is the one which is not taking the dye. So what happens when we have treatment for patients for IVF? As I said, the estradiol level become very high, sometimes can reach to 4,000 to 6,000 nanograms per liter, depending on the stimulation protocol, depending on the quantity of FSH we are giving. And this will put a strain on the hypothalamic pituitary thyroid axis. Of course, this will impair thyrotropin distribution and its kinetic, and it will increase the serum T4 and the thyroxine binding globulin. Of course, controlled ovarian hyperstimulation and ovarian hyperstimulation syndrome marked by increase in the estradiol and thyroxine binding globulin. More severe thyroid function changes than observed in spontaneous pregnancy. And of course, there is a significant increase in TSH compared with baseline values. In hypothyroid treated patients, there is a rapid increase already after 4 to 6 weeks of gestation in thyroxine, and thyroxine is required to maintain euthyroidism, and the timing of such increase requirement is more rapid and pronounced when conception had been achieved after assisted reproduction. So what we do in the clinical management, do we need to screen for thyroid disorders? Yes, we need. But the universal screening is not recommended for all patients who are planning for pregnancy, including assisted reproductive technologies. That's what's the recommendation of the American Association of Endocrinology. But those cases of endometriosis and ovarian polycystic ovary syndrome as well, increased prevalence of, we notice increased prevalence of autoimmune type of thyroid disease, which is a risk factor for the development of hypothyroidism. And of course, as well, menstrual irregularities and hyperprolactinemia. So before we do start our stimulation, there should be enough knowledge about the changes in TSH and free T4 which may occur during the stimulation protocol. Treatment can be postponed for those cases who are having hypothyroidism. We shouldn't put our patients on stress and physiology and psychological burden during the treatment of IVF. And levothyroxine administration is having no beneficial impact on the patients if we are going to just put them on these psychological stress all the time. When do we need to give the treatment for our patients? When they are having positive antibodies, particularly with a history of miscarriage and past history of hypothyroidism, and when the TSH is greater than 2.5. Of course, the dosage should be increased to obtain the level of 2.5 of TSH before we start the treatment of IVF. If we have autoimmune type of thyroid disease, treatment with levothyroxine is recommended before patients develop ovarian hyperstimulation syndrome. E2 increase sharply and markedly, and of course, severe hypothyroidism can develop in those cases. And of course, we need to increase daily levothyroxine dose 4 weeks before we start the treatment of IVF. When we treat with levothyroxine, we can get spontaneous pregnancy in 30% of patients who are having infertility. And pregnancy after controlled ovarian hyperstimulation treatment with gonadotropin stimulation or oral medication, they can achieve pregnancy in 32% of the cases. So in conclusion, despite the levothyroxine treatment, women with hypothyroidism have a significantly decreased chance of achieving pregnancy following IVF compared with the euthyroid. Optimal level of TSH prior and during controlled ovarian hyperstimulation for IVF help in achieving more successful cases. Levothyroxine treatment has a beneficial effect on IVF and pregnancy outcome in infertile patients and subclinical hypothyroidism. And treated hypothyroidism is associated with significantly decreased implantation, clinical pregnancy, and live birth rate compared with euthyroid. These differences may be related to changes in thyroid hormone level and may exert a detrimental influence on oocyte and endometrium. Thyroid peroxidase antibodies affect embryo quality in euthyroid women with low to normal TSH level. Women with high to normal TSH level, increasing TSH level, and possibly TPO antibodies appear to impair embryo quality, and adequate treatment with levothyroxine maintaining thyrotropin serum level below 2.5 may overcome the detrimental effect of hypothyroidism and the paternal subclinical hypothyroidism associated with worse clinical outcome after IVF. is only seen for those who are above 35 years of age. Thank you.